And the next speaker, who we will have this morning, is Associate Professor Tony Walker. And you're here. Yes, he's bouncing between upstairs and downstairs. He's the CEO of Ambulance Victoria, and he's going to give us an overview of the call to establish a global resuscitation alliance. And Nat mentioned how the seeds of this idea started 25 years ago. It came to a fruition in May of last year, and the CAA becoming the Secretariat in October of this year. Tony has more than 30 years' experience in a range of senior clinical governance, education and operational roles, and holds an adjunct appointment as Associate Professor at the College of Health and Biomedicine at Victoria University, and is a Fellow of Paramedics Australia, and also of the Australian Institute of Management, and a board member of the Emergency Services Foundation, just to name a few of the roles to keep him busy. Would you please welcome Associate Professor Tony Walker.
Good morning, everyone, and firstly I'd also like to acknowledge the traditional owners of the land on which we are meeting today and pay my respects to their elders, past and present, and the elders who may be here today. I'm going to spend a little bit of time this morning talking to you about this beast called the Global Resuscitation Alliance. I think, and it was highlighted by the previous speaker, the work that's been underway for the last 30 plus years in the area of better reporting, better standardisation, etc. And when we talk about cardiac arrest, we talk about often the wonderful stories that get the media profile, the wonderful stories of survival. And sometimes we can be lulled into a false sense of security by those N=1 stories of fantastic outcomes, but do they truly represent the systems that you have? And to be fair to say that until most recently, it's fair to say most ambulance services probably didn't really know what their true cardiac arrest survival was, and certainly struggled to benchmark that with other organisations. One of the challenges with that has been this issue of how you systemise response to cardiac arrest. So many people in the room have been intimately involved in developing clinical practice guidelines for decades in the areas of cardiac arrest. Many people in the room have been involved in research, many people in the room have been involved in promulgating community-based programs, etc. But do we really know whether they're making a difference in your respective jurisdictions? And that's one of the challenges that we all face. So this morning I'm going to talk to you a bit about the work that's been underway internationally around developing a system to embrace or encapsulate some of the great guidelines that have been developed around cardiac arrest by the ARC, ALCOR and others. The guidelines provide a step-based linear management of the individual cardiac arrest, but there have been very few pieces of work out there to actually talk about what does the system of cardiac arrest mean and how do you improve it. We all talk about Seattle. We hear about some great work in Seattle today from Michael, and invariably when I hear people talk about Seattle, the first step is, they're different. They're not like us. They're just a small service. They don't have the same issues we face. Their figures are different. They don't measure it the same way. Seattle's just different. Well, Seattle's not different, and I want to talk to you a bit about that. You hear Michael talk about that specifically today. Seattle is a case in point of an organisation that identified an issue around cardiac arrest, measured what they were doing, put in place a range of initiatives, and that led to improved outcomes, and they continue to do so. It's a systemised approach to managing cardiac arrest. So the people from Seattle, a few people from the States, a number of others came together with the support of the Ladle Foundation around 3 years ago now to say, Seattle is not just this special place that does things differently. There is something about Seattle and something about the work they do around the Resuscitation Academy that they've been running over there that actually has a worldwide applicability. How do you take that learning and actually make it applicable and relevant to every other ambulance service around the world, albeit we're all at different stages of maturity, different socioeconomic groups we're servicing, etc. And a couple of speakers this morning have mentioned this, Lynn and Nat, around the issues of survival. We talk about overall survival in cardiac arrest is relatively low. We can talk about some of the great VFET survival rates in services around Australia and other parts of the world, but the overall cardiac arrest is around about 10%. And we all know, and you've learnt this from your early days in ambulance practice, that the chain of survival is a tool to enable you to, where you have those strong links, you have good outcomes in principle. So the Lauderdale Foundation brought together a number of people from around the world, 36 people from around the world, to come together and talk about this issue of how do you actually systemise the management of, systemise the management of cardiac arrest. It was a great 2 days. I had the pleasure of representing Australia and New Zealand at that meeting. I was a bit in awe of some of the people that were there. I've got to say, these are the doyens of cardiac arrest that you read about for many years, and it was done at Esteem Abbey, which was the place that Nat mentioned for the original Esteem work undertaken a number of years ago. And one of the key things after a couple of days meeting there and some really great conversations was that it was very clear that, despite this conversation around 10% of survival, that you can achieve potentially up to survival to up to 50% or more if you have the right systems in place, and that the way you do that is not unique to a place like Seattle. So as a result of that, if you haven't had the opportunity to read this, I would encourage you to do so. There was a publication of a document called The Call to Establish a Global Resuscitation Alliance that provided the evidence. I'm going to go through some of that with you today to talk about how we got to where we got to with the Resuscitation Academy here in Australia. So that gives you a sense of who was there, the likes of Mickey Eisenberg, Tom Ray, Peter Steen, a whole range of other people that were part of this work. And it was a very eclectic group. It had medical workforce, paramedics, nurses, researchers and others with a common goal of improving cardiac arrest survival. So if you just have a look at this, and again, I'm probably preaching the converted here, but it's always good to remind ourselves of what the data tells us, that there are 30,000 cardiac arrests here in Australia every year. In Victoria, from my context, more than 5,800. We know typically overall less than 10% survive. We do know time is of the essence. And we do know, from a system point of view, that where you've got bystander witnessed events, an EMS system activated promptly, prompt CPR and defibrillation predominantly by the system, but ideally by bystanders, and an effective system of care to take them to the right place with the right care, that you get the best chance of survival. It's relatively straightforward, and that the longer you take to get those levels of care, the worse the outcomes. So one of the key elements coming out, you'll hear a lot about this today, is this issue around the 10 steps to improve cardiac arrest survival. And I'll just go through those very quickly for you because they are fundamental to improving cardiac arrest outcomes in your respective jurisdictions. The first up is establishing a cardiac arrest registry. And I'm a very firm believer, if you don't measure it, you can't improve it. And so measuring, and I have to pay credit to SAS and the great work they're doing in that space here and other ambulance services around Australia and New Zealand, around measuring and being able to therefore say how are you going, how do you benchmark, and what are you doing to improve. This important issue around telephone CPR, and downstairs today, one of the other rooms, there's a lot of work going in actually taking these 10 steps and how do you implement those in your respective systems. High performance CPR. I can say from a Victorian context, I have absolutely no idea at the moment what happens once someone walks in the door and once they come out the other end. I know we've got good survival rates from cardiac arrest, and I assume my paramedics are doing wonderful work in there, but I don't know. Don't measure it, don't know. Tell you lots of other things about the system, can't say anything about that. Rapid dispatch, and we've been hearing a lot today about how quickly you can get people, resources rapidly dispatched and identifying cardiac arrest, and importantly starting telephone CPR. Measuring professional resuscitation, which goes into the conversation before about knowing what your people are doing. An AED program around use of other emergency services. I know in the Victorian context, we've got a widespread emergency medical responder program with our firefighters. We have to look at, do we involve the police and others in those programs as well. The use of smart technologies. So how do you actually move this fortuitous conversation? We talked about that this afternoon. Fortuitous conversation around someone walking down the street, coming across someone in cardiac arrest versus being around the corner near an AED, but just didn't know it was nearby as they walked the other direction. So how do you use technology to support that? Mandating CPR and AED training so that everyone knows what to do. Working towards a system of accountability. So not only measuring what you do, but declaring it transparently to your community all the time. It's okay, as long as you're improving. Trust me, we've been reporting cardiac arrest outcomes in Victoria for the last decade, it can be challenging when you're not necessarily where you'd like to be, but it gives you a very strong impetus to improve. and importantly working towards a culture of excellence. So you know this is not new to you. You've seen it in multiple iterations, I'm sure. Everyone's got their own way of doing it, but this has been around for a long period of time, since the 80s, and it still stands today. But to make this work effectively, to get the best outcomes, it needs to be surrounded by this concept of leadership, and the fact you're here today and your colleagues are downstairs demonstrates the leadership being shown by ambulance services to improve cardiac arrest outcomes. This concept of training continuously to improve what we do, the issues of quality improvement, so measure, improve, measure, improve, measure, improve, and this culture of excellence. The principle, and one that we're really having conversations about in Victoria at the moment, excuse me, that no one should die of VF. VF is a survivable condition. If you've got the right system, we all sit there and, I can talk about the fact that in Victoria, we have 53% survival of VF and 38% going home. But what about the other 62% of people who didn't survive? Why didn't they? And what can we do to improve those? So we get very excited sometimes about some of the figures, but what about the others we haven't got? So this culture of excellence of continually improving is critical. You'll hear a lot about that today from people. The Esteem formula for survival that came out of the meeting really is around taking the medical science, the great work done by the resuscitation councils around the world, ILCOR and ARC and others, and ANSCOR and the New Zealand Resuscitation Council as well. This issue around educational efficiency, how do you actually educate and ensure your workforce and all the responders are trained and locally implement the solutions into your area, will improve survival. It's as simple as that. It's simple as that on paper. It's a much more complex issue in doing it, but it is simple as that around how do you improve survival in your respective jurisdiction. So I'm going to go through a couple of things for you now. This is a really interesting slide. So this shows you a situation that might be your service. Some of you might go, don't know because don't measure it, but it might be your service. And you can see there various elements of system performance and cardiac arrest. And you can see there the issues around, your dispatch activation might take 2 minutes. You don't have bystander telephone CPR, or you might have it, but it's it's not as good as it could be. You don't have bystander defibrillation. Your EMS scene time to get there is less than ideal. Issues around EMS defibrillation, etc. And you can see there on the left-hand side, you'll see the poor outcome, and you can see where you get your 10%. You can see where you've got some of your best systems operating, where they've got those things operating effectively and quickly, they can get upwards of 50%. The aspirational elements of it can take you even further. So it's a sense of no EMS system is the same. You'll hear this mantra again today, that if you visited one EMS system, you visited one EMS system. They're all different. And the reality is that the steps to improve survival, despite being different, should be able to be applied in your respective jurisdictions. So, again, one of the key elements coming out of the Global Resuscitation Alliance is this whole concept of successfully implementing your local programs. So the work, and Michael will talk a bit about this as well, the work really is about what do you need to do. The call to establish the alliance identifies these steps, but what do you need to do in your respective area? So part of the work we're doing downstairs today is system assessment. How do you identify where you're at in your system and where would you invest? If you have $1, where's your best investment? In my jurisdiction, my best investment of $1 today to improve cardiac arrest survival is in the establishment of good SAM applications to improve bystander access to defibrillation and CPR, and in the areas of what happens when our paramedics get to the scene, so measuring performance. That may not be the same in other jurisdictions who are very mature in these spaces. So each one is different. It's about identifying where you're currently at, what your performance is, and then identifying where would you get your best return on investment. So if you've got CPR rates, for example, in the 30s, your best return on investment may well be really focusing heavily on telephone CPR. So, as well, it may be your biggest startup investment benefit rather than investing millions of dollars in a community CPR program straight away. Getting people at the scene to actually, your dispatchers to be aggressively pushing this issue of CPR over the phone and identifying cardiac arrest early. And so it's about where you're at, what your figures tell you, and therefore where you would invest your dollar if you're doing it today. This just gives you an example of some of the things, because people often say it's very costly to do some of these things. But you can see there, telephone CPR, in the broader scheme of things, the costs around doing that and implementation changes are relatively small, but the survival impact can be large. High performance CPR, same principle, rapid dispatch. Recording resuscitation, quite a complex issue. I could say it's simple. One of my team who's full-time dedicated to them, I would argue differently about that. So how do you collect information from hundreds of defibrillators around the state and provide feedback in an appropriate way? So and again, from our perspective, you may say, well, we can do all that work, but what would that have as big an impact as, say, a community CPR program? Police defibrillation, large cost, large implementation, but might only have a small impact on performance, survival. And same principle around CPR and AED mandation. So it's really about having a look at your system and saying, well, within what my available budget is today, what am I going to be able to get my best benefit on? And if you can measure that, and I would always argue your first step is getting a cardiac arrest registry. If you can measure what you're doing and you can demonstrate your value proposition to government that you're actually improving what you're doing, they will invest. Invariably, I've seen this happen. They will invest where they see that they're getting improved clinical outcomes because you've demonstrated with the work you're doing you can continue to improve it. With the additional money, this is more that you could do. This gives you an example of the Esteem group through the Washington State Care and Outcome for Cardiac Arrest work. So it gives you an example of how they have improved their various elements across various systems over that period of time. So you can see there, bystander CPR has improved up to 75%. They've improved citizen public exit defibrillation use. They've improved police pad, put in hospital cooling. That'll be a contentious conversation others can have today. Angiography, and you can see there they've moved from a 36% survival to discharge to 46%, and intact survival 43%. So again, it's that principle of where are we today? What are the things I'm going to invest in? You'll hear a bit about that today, and then what through the increment improvement can we see in improved cardiac arrest outcomes? Downstairs, as I said today, you have a number of your colleagues who are participating in the inaugural Resuscitation Academy in Australia and New Zealand. And the reason why there's a strong push for this work to be done internationally is that the evidence tells us that those people that attend a Resuscitation Academy and see and put in practice the things they've seen actually make changes in their system. So today, downstairs, we have invited leaders from ambulance services around Australia and New Zealand who are learning and discussing these things and how they're working internationally with people like Michael and others, and the Australian context as well. But again, you can see there that attending Resuscitation Academy, once you've done one, you can't help but go back and say, well, what am I going to do? And you can see there for that 5-year period, it's made a difference to the implementation of change in people's respective systems. So the system so the Global Resuscitation Alliance is now live and active. Its real principles are very much around taking the great work of ILCOR and others and focusing on systemising that internationally. We've established a 4-continent coordinated infrastructure, so we have secretariats operating in North America, Europe, Asia, and Australia and New Zealand, and the Council of AMS authorities have agreed to sponsor and act as a secretariat for the Global Resuscitation Alliance here in Australia and New Zealand, and David and his team are doing a great piece of work in that space. The real focus of the Global Resuscitation Alliance is simple. It's about promoting the 10 steps to improve cardiac arrest survival, which together are a systemised approach to improving clinical outcomes from cardiac arrest. And very much focusing on this issue of data collection and an Esteem-style registry, so you can legitimately benchmark yourself against your peers and others to see how you're going and identify, well, if they're doing better than me, why? What are you doing differently? And those are the conversations that are live downstairs this last couple of days about, well, how can you do that? How could that work for me? What are you doing in that space? Very much an issue of developing communities of practice, and I think that's one of the great things coming out of the Global Resuscitation Alliance, developing common materials, curriculum that is being shared across resuscitation academies around the world. Very much around annual reporting, how we're going around those things, and ensuring that we've got we're tracking how we're actually improving outcomes, supporting service to improve outcomes around the world. So as I mentioned before, it's up and running. The Australia-New Zealand group, and Lynn mentioned this earlier, has been operating for the last year. We've been running these masterclasses for the last 3 years. This is the third one we've been running, and we're running the first Resuscitation Academy in Australia and New Zealand concurrently with this yesterday and today. And from all accounts, it's having some wonderful impacts on people's thinking and conversations. So in broad terms, the principle of the GRA, and it's not designed to do anything, it's not designed to usurp or get in the way of the resuscitation councils or other work out there. It's really about working with ambulance services as the prime bodies responsible for system coordination of cardiac arrest outcomes in their respective jurisdictions to improve cardiac arrest. And our focus is really about improving survival through system assessment, identifying how you're going through an evidence-based process, training and motivation of local leadership, which is what's underway the last couple of days, developing resources and materials which we're openly sharing, and running the Resuscitation Academy as a place of best practice where we can all learn both here in Australia and New Zealand. And if you haven't had the opportunity, I would encourage you to look at attending the one in Seattle at some point. It is an amazing experience to see how that works. So does it work? So this is just giving you an example. When you measure what you do and when you improve it, you can get improved outcomes. This is from the Victorian Ambulance Cardiac Arrest Registry for 15-16, and just gives you a benchmarking using the Esteem template around survival at various ambulance services around the world. So Seattle, King County, which is the best practice we talk about, is running at 46%. We're not far behind it here in Australia, I've got to say, in some services. And in many cases, we're talking statewide, not city. Those are statewide figures. So you can, the reality of a principle, and we've committed in our organisation to improve cardiac arrest survival by 50% over, say, the next 5 years. It's imminently doable in your respective jurisdictions, applying principles that you're going to be hearing a lot about today. And just to give you another example, that gives you an example of the journey of our ambulance service over the last 12 to 13 years. You can see there the survival, risk-adjusted odds of survival for MS-treated cardiac arrest in Victoria. If you measure and improve, and seriously challenge yourself on where you can make a difference, then you will improve clinical outcomes. So I hope you enjoy the next couple of today for the masterclass. There's some wonderful speakers coming forward. Please enjoy it. I'm having the opportunity to come back this afternoon with Peter to talk a little bit about the use of smartphone applications, and I look forward to catching you both today and over the next couple of days. Thank you very much.